Association in collaboration with WHO Collaborating Center, Imperial College. I would like to welcome everybody to 25th COVID-19 webinar. I'm Badreyya Al Harmi, Consultant Public Health and Vice President of Emirates Public Health Association. Many thanks for Professor Tawfik Khoja and Professor Salman Rawaf and colleagues for having us today. We will discuss today a very important topic about surgery during COVID-19. As we know, this pandemic have challenged all health services worldwide in delivery normal or planned services. Millions of surgical appointments and operations badly needed by the population, with much stress and worries. Some of these are vital surgical intervention for cancer patients and other vulnerable groups. Some restricted services are resumed, but with extensive additional protective measure to protect patients, staff, and institutions. We have to remember that COVID-19 will continue to be with us despite the great news of vaccine development at short period of time, thanks to technological advances. And so today, we do have many areas to cover our topics for tonight with our distinguished speakers who will share their experiences, but also international and WHO guidelines about surgery during COVID-19 pandemic. Let me introduce Dr. Akarshan, who's a surgeon in Kingston Hospital, UK, and Dr. David Rawaf, surgeon in Kingston Hospital, UK, and researcher in Imperial College, WHO Collaborating Center, UK.
Thank you, Dr. Badreyya. So today, hopefully we're going to be talking about the effects of COVID-19 on orthopedic surgery in particular, but we can extrapolate a lot of what we've learned in orthopedics from myself and Akarshan, we'll call him AK for short, from our experiences in working in a busy trauma and orthopedic set of London hospitals. So we have two presentations for you. One is operating during the COVID-19 crisis, specifically in the field of neck of femur fractures, so that's the elderly, and trauma. And also we will be talking about COVID-19 and orthopedic surgery and the new guidelines for from the British Orthopaedic Association for adapting our services to the COVID-19 crisis. So we'll be talking about triage services, we'll be talking about saving crucial elements of the hospital, for example, imaging, and we'll also be talking more about specific management of pediatric as well as adult trauma and long-term conditions. So I'd like to first start by, let me just share my screen here. Can you guys see this PowerPoint?
Yes.
Excellent. So just apologies in advance. AK is operating, he's doing a list of knee scopes, arthroscopies. So he said he was on his last one. He's assisting, so unfortunately when he joins, he will just join with us and I'll get him to chime in as and when. So that's myself there and AK as well. So to start off with, we have the British Orthopaedic Association. Usually, traditionally, they set standards for trauma and orthopedics, and we call these the BOSTs. BOSTs are short standard documents that are downloadable and can be printed for display in hospitals and also tested in registrar and consultant training. The first BOST was published in 2008. By the way, BOST stands for British Orthopaedic Association Standards for Trauma. More recently, the BOA has developed the meaning of the acronym to BOST standards, so BOA standards, to allow a wider remit of BOST to include all aspects relevant to trauma and orthopedics. However, what they've done in response to COVID is updated these guidelines to reflect the new COVID-19 conditions and the pressures that we've been experiencing as a result. The idea is that we want to be balancing treatment, so the optimum treatment versus clinical safety, whilst saving the resources for those affected by the coronavirus. We will be supporting pragmatic decision-making through these posts. So looking at managing a lot of injuries non-operatively. We will be trying to reduce face-to-face contact with patients. So we're not giving passing the coronavirus around. So a lot of remote clinics are going to be done essentially, and have been done over the last 7-8 months. We also want to protect our staff, more importantly. Healthy staff means that we can deal with our patients, and also we are minimizing staff to patient transmission of the disease. There have been a number of emergency guidelines set by the BOA that have been published and are available on their website. And also they are encouraging a number of activities that the managers in the hospitals, and this can be applied to not just orthopedic surgery, but any surgery really, and also medicine, in that we need to build our staff rotas and rosters in a way that is resilient in case we lose one consultant or lose one registrar to a quarantine period. So we need to prepare for that fact. And a lot of retired consultants have been asked to come back, not physically to the hospital, obviously, but to run remote clinics or even run triage services of imaging that has been performed by the emergency department. We also are aiming to look after our staff. So the BOA recommends setting up staff wellbeing services, monitoring the staff, no matter how junior or senior, making sure that everyone is fit to work. And also ensuring that all staff do have access to remote working facilities, which is obviously very key. So especially those in the imaging departments need the correct kind of internet access, which is, so they're able to download CT scans quickly and go through them quickly. We also need to make sure that the equipment and resources are allocated, including PPE, and also within the theatres, for example, in the theatre, in the operating room, we have a lot of items in there. A lot of those items have been taken out. Things like spare sutures or even spare gowns, spare tools, things like that are kept aside. Spare staff that do not need to be in the operating theatre because of the aerosol generating procedures that are occurring in there are kept outside, minimizing the need for use of PPE for those that don't need it. So those outside are simply preparing items for the surgeons inside and the scrub theatre staff inside. And also documentation. Every patient that is seen or treated during this COVID-19 crisis, it needs to be written down that they were treated during this crisis, and thus their treatment was not as it was prior to the COVID-19 pandemic. So those were general considerations, as I said, can be applied to not just orthopedics. So outpatient management, this is a key question I think that we're going to hear later, is how do we deal with the masses of patients that are waiting in the outpatient department? Traditionally, we have had long waiting times in the NHS prior to the COVID-19 pandemic, but now these waiting times have tripled, maybe quadrupled. We don't really know the full extent of the damage, and I'm sure the same goes around the world. So in order to try and tackle this, we need pragmatic and experienced approach to dealing with this, and that is really centered around the consultant delivered and senior surgery scheduling occurring that will allow juniors to rely on their seniors and not having to do operations unnecessarily, essentially. Any patient that does attend the outpatient department, whether it's face-to-face or whether it's remote, if we need to schedule an operation, there shouldn't be any time wasted. We should schedule it and get on with it. We should be making these decisions at the first attendance. There is also a suggestion from the BOA that we should have a 7-day trauma clinic triage system from the emergency department. The emergency department is heavily relied on by all surgical specialties. They are going to be initially diagnosing, starting management, and also referring to definitive care. Traditionally, the definitive care would involve seeing another surgeon in the hospital the same day, but however, with the resources available and also to minimize spread of the coronavirus, we want to minimize this by introducing a triage system. So the emergency department can refer to a trauma clinic This doesn't have to be trauma clinic. It could be an abdomen clinic. It could be a vascular clinic or plastic surgery clinic. But the clinic can be referred to directly from the emergency department. And those consultants that are triaging, or seniors that are triaging those clinics, can view the images, the case files, everything very quickly, remotely, safely, and are able to then decide who needs an operation, who can wait. The GPs and the MIUs, so the MIUs is essentially the urgent treatment center or the minor injury unit. They should have a direct access to trauma and orthopedics or any specialty advice, whether that be via telephone or electronically. They should be able to contact someone in the department, necessary department, quickly for advice, so that they're able to take that advice and perhaps send someone home. If the advice is conservative management, that's even better, because then we don't have to admit the patient, and that bed can be kept for someone that has coronavirus. We want to minimize the need for attending a physical trauma clinic by doing this. So we do have these remote trauma clinics that the trauma and orthopedics service can tell the emergency department or the GP or the minor injury unit to refer to. We also need to minimize the need for imaging, and this is a very important point. The resources available for the hospital is limited. The CT scanner can only handle so many patients in one day, and in order to diagnose coronavirus, you do need a CT chest. You need the CT chest and potentially abdomen, potentially brain if there's any associated microvascular compromises going on as a result of the coronavirus. So we need to rely on seniors as well as juniors using their clinical acumen, and also to be only performing these images if absolutely necessary. For example, if there's a significant change in management, or if this is a serious injury. And also the BOA have suggested using the mini C-arm. So that is a small, it's essentially a device that we use in the operating theatre, where we can take x-rays whilst operating. So we can check the position of metalwork, etc., and the reduction of fractures. And essentially to be able to make sure we utilize that equipment that is otherwise potentially not being used all the time. We can bring that down to the trauma clinic and take images of patients right there and then with the consultant in the same room, without having to go to the imaging department, thus minimizing spread of coronavirus, thus minimizing the pressure on the imaging department. Follow-up of these patients is necessary, but it doesn't have to be face-to-face. And so what we're, essentially what we have been advised on is to cancel, maybe postpone, or conduct these follow-up appointments remotely. And again, this goes back to our general considerations. The staff need to be trained on how to use these remote services. The patients need to understand how these remote services work. So obviously there are, a number of cohorts, especially the elderly cohort, that may not have access to certain devices or internet. But more importantly, we need to also make sure that the staff have the equipment to be able to do this. We also want to minimize the pressure on the rehabilitation services by providing written and or web-based information in advance. So at the point of follow-up, or at the point of when they reach the emergency department. So our emergency department colleagues will be leaning on them to be providing as much advice as possible at the time they attend the emergency department. The reason being for this is that a lot of the therapists, physiotherapists, are being redeployed, and they're being redeployed to monitor the ventilators, or to run errands in the intensive care unit for the coronavirus patients. And it's very important that we look after that resource essentially. So next we have specific injuries. So just to talk about these specific injuries very briefly, we have dislocations, for example. This is a very common injury. We're relying again on the emergency department, or the minor injury units, or even the trauma clinic, the face-to-face physical trauma clinic, to be able to reduce these injuries, without having to call our anesthetic colleagues, asking them to perform a general anesthetic, or taking them up to theatre where, essentially we are taking an anesthetic doctor away from a coronavirus patient, or we are taking a ventilator away from a coronavirus patient. We want to minimize the need for heavy sedation for these dislocations. So we need real expertise here. The same goes for upper limb fractures. We want to minimize the need for operations. So these can be, a lot of these injuries can be managed conservatively or non-operatively. Especially in fractures that have high rates of union, such as the proximal humerus fracture, especially in the elderly, where we wouldn't look to be operating on these immediately. Ligamentous injuries of the knee and the elbow, we can brace these injuries initially, manage them conservatively as per the BOA guidelines, and then go on to following them up remotely, seeing how they're doing. We could even encourage some physiotherapy and advice over the phone, and see how they do in the long run. These injuries do not need an urgent operation. There are certain injuries, such as penetrating injuries, stab wounds, things like that, that can be managed in ED, especially if they're non-contaminated or non-neurovascular compromised. As long as that has been established, then we can manage them in emergency department, suture them up with absorbable sutures, given proper wound care, and sent home so that they're able to, stay at home and not come back into the hospital. The same goes for abscesses. As long as the patient's not septic, an incision and drainage can be done in the ED or the trauma clinic or in the MIU. And we can send them home again with the correct advice and maybe a follow-up remotely, again, as to minimize the need to come into the hospital. So just moving on to inpatient management, we want to only be admitting if there is no alternative. Each bed is crucial at the moment. It was back in March, more so in the UK, but now we're having more and more admissions of coronavirus cases, and each bed, even on our wards in the orthopedic department, we have more coronavirus patients in that ward than we do have orthopedic patients, and that's because we're sending the orthopedic patients home. We're looking at staging management of certain orthopedic injuries or complex cases, where we can perform one part of the management, send them home until they're ready for the next part, so that the bed is available in the meanwhile for a coronavirus patient. Anyone that needs an operation but is ambulatory, that can walk around, we bring them to the day case center or to an elective center. These are centers that are traditionally clean. For example, I spoke last time, I think this was back in May, about how the elective center was turned into a temporary intensive care unit. However, that's been cleaned up. It's been closed from the coronavirus, and it's reopened for the elective work that really needs to be done so we can tackle the waiting times. And those are designated clean, green areas. So there are no coronavirus cases. Every staff member is tested twice weekly, and any patient coming in for an elective case is tested twice before the operation. So we can send patients there, if there are simple periarticular fractures, foot and ankle injuries, simple upper limb injuries that need an operation that cannot be managed conservatively, can come to those areas. So we don't have to take them to the main theaters in the main hospital, which is a dirty area. It's a red area. So moving on, the major trauma network. So this is an American system that has been adapted by the UK. In London, we have 4 major trauma hospitals. And it's important for them to communicate with each other about distribution of workload, and not one hospital taking more on than the other. For example, at the moment, St. George's, one of our major trauma network hospitals, is inundated with coronavirus cases. So perhaps the local major trauma centers such as King's or St. Mary's can take on some of that workload as a result. And it would have to be quick and adaptable depending on which areas have more coronavirus cases or more injuries happening. Of course, in the theaters, any patient that is being operated on will be operated on, there will be drills and saws, and this is more applicable for trauma and orthopedics than other surgeries. However, there is, we still use these tools in neurosurgery and maxillofacial surgery, ENT, etc. There is still aerosol generating high-speed devices being used. So we need to make sure the staff in there are wearing appropriate PPE, and also the staff that do not need to be inside the theatres are outside the theatres, and that there is a buffer room where the tools are kept and things are kept clean. We want to minimize the stay of any patient that does end up coming in. So as I mentioned earlier, stage management is an option. This could be very applicable to abdominal surgery, bowel surgery, where if we're doing an emergency, we would be able to do that emergency, send them home with a stoma, for example, and then bring them back later for a definitive management, as opposed to keeping them in as an inpatient throughout their stay and risking them to coronavirus and risking the staff to coronavirus and also taking away a bed. And a key point I mentioned earlier is using absorbable sutures when possible, giving lots of wound care advice, so that we're not giving pressure on the district nurses or the general practitioners, and allowing them to focus on the emergencies that they have and not simple removal of sutures. Spinal fractures, of course, those that are not neurosurgical and uncomplicated and conservatively managed, can be managed with braces. And again, these braces should be stocked up in emergency departments around the world, and they should be given to the patients, taught how to use them, and given clear instructions on what to do next, and obviously with remote follow-up. At all times with these remote follow-up procedures, the advice is that we have to safety net, and we have to make sure that they're aware of any red flags that may occur. For example, incision and drainage. We have to give them the early warning signs of sepsis. So if they have any of those signs, that they themselves can then flag up and come back into the hospital. Also, further to this, we do have, in every specialty, there's usually a specialty nurse that is able to provide their phone number to the patient. The patient can then call that nurse if they have any concerns. And the nurse can do a triage almost and decide whether they need to come in and be seen, or whether actually this is just to be expected as part of the recovery. So next slide is about orthopedic emergencies. And this is where AK, I was hoping AK would chime in about some of the lower limb fragility fractures, but we'll see what time he finishes. If not, I will cover for him. So life and limb threatening injuries. So these are obviously going to be managed as standard as per the emergent resuscitation and management guidelines, both from BOA, from NICE, or from any of the other colleges that related to their specific surgeries. We cannot risk life or limb, of course. And the same goes for these specific injuries here: cauda equina syndrome, spinal injuries with neurovascular compromise, septic joints, especially if they're infected replaced joints, so infected metalwork, or infected fractures or open fractures. They require emergency treatment as per the normal guidelines. And this is now applicable to those in the plastic surgery field. We should consider alternative techniques for soft tissue reconstruction. We want to avoid multiple operations using vac dressings, using complex post-operative dressings that need daily review. We could look at different ways of managing those injuries. And of course, some of these injuries, some of these soft tissue reconstructions, such as Fournier's gangrene, things like that, will need critical care input. And we want to minimize the need for that. Every bed in the intensive care unit and every anesthetic doctor is crucial at the moment, and we need them to be focusing on providing airway and ventilatory support for the coronavirus patients. And again, moving on to other specific injuries, those that may require amputation, sadly, will need to have that decision made earlier. Limb salvage may not be applicable in certain very complex cases, and as such, that decision needs to be made early. And that goes back to my first point, which is that we need to have the whole service centered around consultants and expertise, and decision making needs to be very pragmatic. Vascular injuries or neurovascular compromise, decision-making should be made on clinical assessment. We want to, again, minimize the use of the CT scanner or the CT angiogram as much as possible. We want to avoid putting pressure on the imaging department. And lower limb fragility fractures, we've seen quite a lot, a rise in that since the lockdown ended, although we went through another lockdown. But even during the lockdown, we had a lot of elderly patients or elderly people back at home that were unable to go out, and their friends and family weren't able to visit them and help them out. So they were doing more things around the house and risking injuring themselves. We did have quite a lot of neck or femur fractures come in during that time. And generally, we do have a set of nice guidelines that allow us to decide whether a neck or femur fracture would benefit from a total hip replacement versus a hemiarthroplasty. And we want to, obviously, in this country, in the UK, total hip replacements have to be performed by a consultant hip surgeon. But however, the on-call consultant is not always a hip surgeon. And this is a crucial point, really. The idea is not to say a hip fracture comes in on a Friday afternoon and she's usually, or he or she is usually a very, very ambulatory patient. She plays golf and she walks around lots, and maybe she does everything herself, but unfortunately she broke her hip because she tripped on the stairs. So this patient usually would be qualifying for a total hip replacement and would probably have to wait until Monday or Tuesday until that hip surgeon comes into the hospital or is on call. However, in this scenario, in coronavirus, those patients are at very high risk if and when they have coronavirus, and their chances of catching that is much higher in the hospital. So the idea is to opt for the hemiarthroplasty earlier. This is a half hip replacement, and it has very similar outcomes in terms of quality of life and mobility scores. And the idea is to make sure that they're able to get this patient fixed and out of the hospital as quickly as possible. Both can weight bear on the same day. So the idea is to reduce the inpatient stay as much as possible. This is where ideally would bring up AK's slides now, but he's still operating. So I'll continue with this PowerPoint presentation, and then we'll move on to the next one as and when. So moving on, we'll talk about hand injuries. So obviously hand injuries are very common. They are, the majority of the injuries that come in to the hospital and walk through the emergency department doors. And the idea is that rather than relying on the one trauma consultant, we would have another consultant on call who would be the lead consultant for hand trauma. We would be aiming to reduce as much as possible face-to-face contact between that consultant and the patient. So we'd relying on retired staff. I mentioned this earlier. The BOA have suggested exploring the scope for allowing retired staff to work remotely in triaging these patients by looking at the imaging, by looking at the cases, and coming up with definitive or next step management plans. We're also going to be relying on the emergency department, of course, in order to remote triage and streamline this triage service. They can, as per their own guidelines, treat and manage a lot of hand injuries. And we can then, as a definitive trauma and orthopedic team, can see them in a remote fashion. Those that need operation, as I said earlier, would be teed up as soon as possible in a day case in a clean area. That means we can, test them in advance, make sure that they don't have coronavirus, and we can operate on them knowing that we don't have to waste PPE, that we don't have to waste a main hospital bed. Complex injuries, of course, those would be operated on same or next day. And there is a technique that has been suggested called the wide awake local anesthetic, or no tourniquet, so the WALANT. So essentially trying to perform these hand and wrist surgeries under local anesthetic block that can be administered by the surgeon. So there would be no need for an anesthetist present, no need for a ventilator, and obviously the aerosol generating associated with intubating the patient. And then obviously the anesthetic involved with intubating the patient would minimize the need for an overnight stay in hospital. So they can be day cases, even for the complex patients. There we go. So also we want to make sure that we have appropriate plaster room technicians, good supply of all the splints, hand splints, knee splints, braces, shoes, things like that needs to be well stocked up. So this is, now looking at the management and the logistics side of the hospital, making sure that these equipment and these items are at high levels. Also, K-wires or Kirsch wires are used very often in a lot of injuries, especially in pediatric injuries. And traditionally, we would bury them so as to reduce the chance of infection and also to facilitate, a better wound appearance, a better finish. However, the BOA is suggesting leaving these K-wires unburied so that they can be taken out in clinic without having to send the patient back to sleep. The same goes for the dressings and the splints. Everything that we give to the patient in terms of conservative management or even post-operatively, if we're going to be putting on a cast post-operatively or during the operation, we want something that's easily removable. It doesn't need to be, brought in back to the hospital to use a special machine to cut the cast. We'll be looking to use things that are easy to remove as much as possible. So then when we know that the patient is ready to have that removed, we can tell them remotely, you can take it off. You don't have to come back into the hospital. And this goes on, talking about discharge packs here. Traditionally, we would give a couple of days of antibiotics, bring them back, review things, give them more antibiotics, bring them back for a wound check, give them analgesia if their pain is not controlled, etc. What we're looking at is streamlining that rather than bringing the patient back and forth. We want to give one package straight away. And this would be beneficial for the future anyway, to minimize footfall in the hospital, to give one pack that includes everything: antibiotics, spare dressings, analgesia, post-op instructions, specific wound care advice for their operation. Different operations have different wounds. And as a result, we need to make sure that the patient is up to speed on what they are going to be expecting with their own wound. And I've talked about this previously, but we need to anticipate these hand therapists and the hand therapy team may be redeployed, and we may not have them readily available. So we need to be giving proper and in-depth advice about how to maintain their joint mobility and also to maintain their muscle strength and their muscle mass post-operatively. So really, we're going to be having to act as both surgeons and therapists in a way. If we start to lose more and more therapists. Pediatric trauma is a very pressing issue. We need to obviously, as previously mentioned, have an emphasis on non-operative strategies, minimize outpatient visits and footfall in the hospital. But as normal, we should always consider the possibility of non-accidental injury. With everyone being at home constantly, everyone's very stressed. The coronavirus has taken its toll on people's mental health. We do have an increased chance of domestic abuse, things like this happening at home. And we've spoken about this in the previous webinars on mental health. So we cannot ignore that fact. We cannot just simply, just brush aside a pediatric fracture and just continue to manage it without, closer scrutiny. We need to make sure that we're not missing anything dangerous or that could happen again at home. These kids can, be managed without imaging them initially as well. So again, easing the pressure on the radiology department, especially soft tissue injuries or upper limb long bone fractures that have an obvious clinical deformity. We know that it's broken. You don't need to take a picture of it as such, and we know we're not going to operate on it. Foot fractures, again, without significant clinical deformity, can be managed conservatively and based on clinical acumen. Also, managing without a cast. Cast on kids are very difficult to manage. They get wet, they get drawn on, they get, food gets spilt on them. It increases the chance of having an issue with the cast. So we ideally want to manage as many people without casts as possible. So things like locking knee braces or walking boots, Stable ankle fractures can be managed with a fixed boot as opposed to a below knee cast, or foot injuries can be managed with a fixed boot or plaster shoe, rather than, again, a below knee cast. So, and obviously following these patients up, rather than saying, look, we're going to give you an automated date to come back in, we will allow the patient's parents to initiate that follow-up. So say if the pain is increasing, or if the pain is not improving, or if the deformity that we would have corrected has returned, things like that, we would put the onus on the family and the parents to direct the patient or direct us as to when we need to bring them back in. And that will also help us with triage, triaging those that needs to be seen sooner rather than later. And again, same as adults, utilizing the day case and the elective centers as much as possible for these operative cases. Continued pediatric trauma, those that need to come in so these are specific things here, open fractures, any fracture that we need to operate on, we would consider doing a washout, obviously, in theaters and fixation, but then obviously applying a cast that would have a window on there, so we're not having to open the cast again and again, minimizing aerosol generating procedures. Those that have septic arthritis, osteomyelitis, those with femoral fractures over 6 years, displaced articular or periarticular fractures, they need to come in and as per the usual set of guidance. And here the BOA have actually stratified the pediatric cases into 5 different areas. So emergency, less than 24 hours, non-accidental injury, obviously they need to be protected. Things like septic arthritis, osteomyelitis, or new neurovascular compromise in fractures. Urgent cases can be, can wait a little bit longer. Things like slipped upper femoral epiphysis, severe pain, exposed metalwork, things like those can be monitored from home initially. However, we need to watch for sepsis, obviously. There are things that are time dependent, as seen here. So we've stratified it into 4 to 6 weeks or less than 3 months. And there is a lot of overlap between the two, but really it depends on how severe the case is. So, we have developmental, so DDH, for example, developmental hip dysplasia, those that are suspected cases, or those currently undergoing harnesses or plaster immobilization, should be seen sooner than those that need a primary open reduction. Those can potentially wait until we've dealt with the coronavirus a bit better. Non-urgent, more than 3 months. There's things that have an established deformity or long-term joint instability, or metalwork that needs to be removed because they can feel it through their skin or something like that. Those cases can wait, and they don't need to come in urgently. So the BOA have actually defined these in order to help the pragmatic decision making. So I believe this is the last slide here. So what I'll do now is I can move over to AK's presentation, or if you wish, we can discuss a little bit, give AK some time, give him a chance to join us. What would you like to do?
Let us, Dr. Badreyya, with your permission, let us have a discussion now.
Yes.
If Kay could join us from his theater, then this would be great.
Awesome, I'll see what I can do.
Okay, thank you very much, Dr. David, for this interesting talk. So now I think we will move to the panel discussion, and it will be open for all your questions. And this panel discussion will go with Professor Salman and Professor Tawfik Khoja. And I hope you will enjoy our talk for tonight.
Thank you, Dr. Badreyya, and thank you, Dr. David. It's really fascinating, It did show us the magnitude of the work you do in surgery. I mean, sometimes for people who are not familiar with David, with what you described, taking surgery is surgery, sometimes this is the way we describe it. But the magnitude is really unbelievable, the amount of the work, procedures, etc. We have a lot of questions, actually. with this changes which almost imposed on you in surgical firms, whether orthopedics or general surgery, GI, urology, gynecology, name it. What patient safety is compromised?
That's the idea of doing all of this and trying to outline it in the way that the BOA have, and I'm sure other specialty colleges have as well, is that we need to ensure that patient safety is not compromised and that safety netting is provided to every patient, and that if there is any concerns about the patient, there is a quick escalation pathway and an easy way for that patient to get in touch with the hospital. Now, patient safety, in my experience in orthopedics and the coronavirus, I haven't personally seen, any specific cases as such. But in general, the trauma service has been maintained throughout the whole coronavirus, and the idea is to make sure that there is no, patient safety issues. There are, I would say, more in the world of anesthetics and coronavirus, where, especially initially when we were managing those patients in the ITU, we didn't have proper guidance from NICE, from National Institute of Clinical Excellence, and we didn't have we didn't have the evidence to manage these patients. So I would say yes and no.
Yes and no. I mean, this is this is a key question. Yes and no. You are discharging patient early. Or indeed, instead of admitting, sending their home, and you follow them by telephone or virtually or through some remote services like nurses, etc. But this is increasing the chance of infection, for example. I mean, how that, I know it's an emergency situation we are in. I know it's a unique situation we are in, but how that could be really addressed and how much we can learn from it at the present time for any future pandemics, which we are sure that there will be more pandemics in the future.
I'm sure there will be as well. I think what we're learning, this pandemic has forced us to actually be more resourceful. And I would say the way that previous clinics, not just in the surgical world, but also in the medical world, have been potentially wasteful. We've been seeing patients unnecessarily, just to check up on seeing how they are. Oh, yeah, I'll see you at 6 weeks, and we see them at 6 weeks, and they're getting better, and there's nothing going on. This is the majority of patients that are actually doing okay. And obviously, the whole point of following them up is to catch that small minority of patients that do have post-operative complications, as you say, infections or sepsis. But I think a lot of that obviously is based on clinical acumen and being able to see the patient and being able to speak to the patient. We're still speaking to them. And now we have the technology still to be able to see them through the camera. And I've seen it with my own eyes. I've seen my seniors and my registrars and consultants. They have video conference. They've sent images back and forth from the patient. We would ask for a picture of the wound. We would give them a cast that's easily removable, so we could say to them, look, we'll follow the instructions, place your leg carefully, open the cast, let's have a look at the wound. We're able to still assess as we would do normally. However, obviously it's encouraged us to be more resourceful and encouraged us to also utilize safety netting. And that is really the key thing, is safety netting and teaching the patient on how to, and educating them how to look after and to keep an eye out for themselves and to know when to raise the flag.
I mean, I'll come to this point because this is an important point, but let me pass to Professor Khoja with his set of questions. Professor Khoja.
Thank you so much, Professor Salman. This is a great opportunity to listen to this very vital subject. And thank you, Dr. David. It is a great and at the same time very comprehensive approach towards surgery in COVID-19 pandemic. And thank you, Dr. Badreyya, for leadership in this session. I enjoy your chairperson for such an important subject. Actually, let me start with this. We are facing with 3 key areas of current challenges for surgery in the period of COVID-19 pandemic. Is surgical patients and the surgical workforce and the surgical process. And I am very thankful to Professor Salman. He start with the 3rd one, which is a surgical process starting with patient safety, because I have the same inquiry, same notion what he's saying. We have WHO surgical checklist patient safety. I wonder in normal surgery we have difficulty to apply in normal surgery. You know, I am very interested in patient safety. How in emergency, and you raised so many areas, Professor Salman raised so many areas, but still, unless we do studies about issues of patient safety, I think we are giving not the full picture about patient safety during pandemic. So I think there is missing areas. We are missing a lot of areas in healthcare management during pandemic. We concentrate only on COVID. So I think there is missing area in surgical parts. So really, I would like from you as a consultant and same time in a very respected college, Imperial College, to highlight and to let other people, as your father, Professor Salman said, we need to learn for the coming pandemic, not only this COVID. This question is a great question, and I think we need to highlight more. Another question I am asking, in countries like UK and other countries like Saudi Arabia and others, we have a long waiting list for routine surgery. All right, and how can you and your colleague and the NHS will cope after COVID? How they can combat the backlog? Really, this is worrying. My son, he's also orthopedic surgeon, Yusuf, like you. Always we discuss this issue. How can you go? There is a waiting list, long waiting list before the COVID. So how can you cope after COVID? My question to you, Dr. David. I am sorry.
It's very good. 2 very good questions. I think, you know, starting with your first one. So, you know, not concentrating on COVID is a very important point. I mean, obviously, we are not anesthetics. We are not intensivists. We are surgeons. And whilst we have been redeployed and helped them out previously, we do need to start focusing on our services. And that actually moves on to how we're going to manage and cope. But first, I mean, the way that we're going to do this is by auditing our process, and we have to continuously be auditing our process and performing quality improvement projects. You know, the BOA, actually, a lot of these guidelines were audited in Swindon Hospital. I can give you the link for it afterwards, but essentially they went through each one of these new guidelines and applied them. We're seeing how well they were doing, noting any serious incidents, you know, seeing the percentage of cases that we're seeing that were transferred remotely, and seeing what effect it had on our waiting times. And these guidelines did very well. It's been proved to already. It's already been proved to have worked and to have helped the hospitals with their situation. Moving on to your next question, Professor, how to manage and cope after COVID. It's a very good question, and I will be honest, it's very difficult to answer. However, I know in the UK, and especially in the hospitals that I've worked in over the last year, we have reopened the services, the elective services, and we have started to tackle that waiting list. I think pretty much as soon as the first lockdown ended, we cleaned up the elective hospitals that were transferred into ITUs, and we started bringing patients back. However, things are slower. We are having to clean in between each patient more in depth. We're also having to test patients before they come into the clean areas and the elective areas, and we're also having to do more paperwork. There is more paperwork to do. The patient needs to sign that, you know, they may catch coronavirus, and as a result, things are slower, and the waiting list is growing. There are more and more people that have injured themselves during the coronavirus with long-term conditions that need a replacement or need a ligament repair or something that needs to be done and the list is growing, and it's going to be very tough. We have seen some hospitals outsource these waiting lists to local private hospitals. We have seen some retired staff come back and do extra shifts. We have seen some, some patients simply go to the private healthcare anyway. Obviously, I think in Saudi Arabia, you have a different tiered health system to ours, so it's going to be a slightly different approach. However, we're still going to have the same problem, which is that the lists are growing, and we still only have the same number of staff. Looking at using and utilizing junior colleagues as much as possible is going to be crucial at this time. Obviously, we cannot magically create another 1,000 consultants. However, we do have 1,000 juniors that are working their way to becoming a consultant, and utilizing that workforce as much as possible is important, with also whilst not hindering the coronavirus response.
David, thank you very much, and it's a great question from Professor Khoja. Carry on.
Thank you, Khoja. If you permit me, Professor Salman.
Yeah, carry on, please.
Thank
Lovely
you.
Questions.
Allah bless you. Dr. David, I listened to you that you have triage in different aspects in your surgery and orthopedic management of patients. But to me, as a family physician, it is in the last 9 months or 10 months, there was a question to my mind hammering me so many times. I understand during my training that it is easy for us to have triage for medical condition, for pediatric condition, but for surgery, I think I think it needs from the first step a surgeon to see the patient and straightforward to go to the surgical side. I mean that time is very crucial for a surgical patient. Second, I feel that if we can make triage for everything except surgery, it should be looks as an emergency rather than a nurse seeing the patient and a telemedicine seeing the patient, GP seeing the patient. So what do you think about this issue? Could you please elaborate?
Of course, please. Thank you. That's a great question. I think part of utilizing the services that are already in the hospital, such as the emergency department, allowing them to help triage, giving them access to the specialists. So, the hospital will still have a general surgeon, will still have a urologist, will still have a trauma and orthopedic surgeon, maxillofacial, ENT. They will still all be on site, whether they're in that hospital or the neighboring hospital. They need to have access to that specialist 24/7. And they need to be able to give advice back to the emergency department on whether this patient needs surgery or whether they don't. And that's going to be down to clinical acumen, down to how well the emergency department can assess and see these patients, and also allowing the specialist to be able to go down and see these patients without to make sure that we're not missing cases that need an operation urgently. And that's for the urgent, that's for the trauma, that's for the the people in the emergency department. But those in the elective world, so those in the outpatient world that are awaiting surgery for chronic conditions, again, the same can be applied, where they need to be able to see a surgeon or a specialist if they need it, and that's where the advice, that's where the remote working and delivery of outpatient clinics needs to be streamlined, and it also needs to be safety netted. And again, I come back to that phrase, safety netting. We need to be educating patients. We need to be also educating our colleagues in the emergency department. A lot of the doctors down there are non-specialist. They're working in emergency department, and they may not have experience of general surgery or trauma and orthopedics. So we need to allow them to call us, and we, without a steep authority, a gradient. We need to allow them not to fear calling us. and not to think, oh, I'm going to waste their time or anything like that. No, we're in the hospital anyway. You need to call us. You know, we don't want to miss something, because then it will be even worse for us later. We will have to clean up the mess anyway. So it needs to be hammered home that the GPs, the minor injury units, the emergency departments, they all need access to these specialists quickly and easily. And if they need a pair of eyes or a pair of hands on a particular case, they need to be able to bring them down as soon as possible. I agree with you. You know, we need to be able to triage these patients properly. We cannot cut any corners, because otherwise we're going to find patients further down the line with worse problems, with worse outcomes, you know, and coming back to the hospital with worse, you know, with a worse management plan.
Okay, I have two more. Let me start with this one. In Italy, I read so many times that the workforce develop burnout, heart sinking, and they cannot cope with the pandemic because they are working over their limitation, more than 24 hours. So they took surgeon to work in the anesthesia department. They took surgeon to work in the ICU, and so on and so forth. Do you think, as you are a practicing consultant, do you think this is a right decision? And is it something we should follow in pandemic, or we should look to the workforce as in general to be prepared in a different way? I mean, I don't know. I cannot ask the surgeon to become a family physician or a family physician to become a surgeon. Same thing. So it is something I cannot comprehend. So what do you think about this approach?
Yeah, this is a tough one. Actually, I've just got a message from AK. He's going to try and join us now. This is a really tough question. You know, I'm not a consultant. I'm a you know, junior SHO, senior house officer, core surgical trainee. You know, our level were redeployed. I spoke about this at length in our previous webinar. Both AK and I were sent over to the intensive care unit for up to 10 months. We were there for a long time. We were looking after intensive care patients. We didn't have intensive care training. We were having to look after airway patients when we weren't airway trained. You know, I agree with you. It's not right, but it's the only thing we had. With the sudden influx of patients coming in, that was the only option available. And I remember having to teach. You know, I was teaching medical students that they had brought from the medical school to help, teaching them basic things like arterial lines or arterial blood gases, or simple procedures. I was teaching physiotherapists how to manage a fluid chart, or how to you know, add up all the different you know, or how to calculate a map, for example. You know, these things we were put on the spot. We had to learn ourselves on the spot. You know, and our senior colleagues would have to teach us something, and the next day we would have to teach someone else the same thing. You know, the student became the teacher very quickly in that pandemic. And whilst I don't, you know, obviously this is not the best and not the most ideal scenario. I think it was the only thing that we were able to do at the time. And as a learning point for the future, and I mentioned this last time, I do believe that the whole multidisciplinary team, whether you're a nurse, whether you're a physiotherapist, whether you are a doctor, you know, I believe that at the early stages of their training in the medical school or in their training, they should have some form of intensive care experience. If we're going to experience another pandemic, if we want to be prepared for another pandemic, we need to have every single part, every single aspect of the workforce. Even we need to have the porters ready to be able to know how to turn on a CT scanner if need be, for example. Everyone needs to be ready to do someone else's job if need be. And I'm not saying this is, you know, something that they should have a qualification for, but it should be in the curriculum. And currently intensive care is in medical schools, intensive care is left until maybe the last few weeks when you're in final year. Maybe you'll get a few days of experience in there, and that's it. It's not enough. We need to bring these students early and teach them and train them in intensive care, so that they're able to assist if we have another pandemic, if this happens again, we have another lockdown or another surge of cases. And that goes for the surgeons too. Surgeons need to be adaptable and resilient, and as a result, you know, AK and I have gone through that. We've seen what it's like to be put from surgery into intensive care overnight, and here we are. I think we have AK has joined us now.
Okay.
And yeah,
let me welcome AK, and thank you very much, AK, for Mr. AK, for leaving your surgery theater and joining us. Obviously, you look like somebody just left the theater. Hopefully the patient was okay, you know. David, before we ask AK to actually present his views and experience, I mean, you raise a lot of issues to us, and I want to reflect on this with Professor Khoja and Dr. Badreyya, i.e. zooming on the Arab region. What you talk in terms of testing before admission, the issue of in-depth cleaning between patients, the issue of leading that to fewer patients seen per session, you know, the expensive PPE, the use of more disposable material, discharging patient early and follow it through additional staff, which visiting patient at home. These are at a huge cost. Such costs may be manageable in the United Kingdom, which is the 5th richest country in the world. But if you take our region, we have 22 countries, only the GCC, not all of them, 5 of the GCC are rich countries, or 4, you know. The rest of the Arab world are not rich enough, you know, for them actually to cope with such pressure on services. Dr. Badreyya, how do you think Arab countries could cope? Will be Egypt coping with this, Somalia, Iraq, you know, Syria in their current situation, Jordan with very stretched services, Morocco, again, very stretched funding, Libya with the war they have there. How these countries will cope with the way Dr. David described in terms of surgery today during COVID and possibly for a couple of years to come? Dr. Badreyya.
I think, Doctor, during the pandemic, we learned a lot of lessons. One of them, how to reallocate our resources. This is very important, and how we prioritize important topics. Okay, and about the surgery or surgery during COVID-19. Also, we mentioned that a lot of surgical operations are postponed or delayed because of the COVID. But I think with the reallocate our resource and as well as according to the priority of the surgery itself, they can cope with this pandemic.
Thank you, Dr. Badreyya. Professor Khoja, with your vast experience from the GCC Health Council, as well as the Arab League, how the countries which I mentioned can cope with all these extra procedures at a huge cost? It may actually double the unit cost, if not triple it. Although we don't have studies to show how much the cost increased, but obviously from the description by David, it's a lot of increase in cost, unit cost.
Thank you so much. This is really, as I am going to use the terminology of David, Dr. David, tough question. This is a tough question. Really. I think Dr. Badreyya answers some part of it, but still I'm trying to have a good answer in this issue. As Dr. Badreyya tried to answer it. First of all, let me say that the GCC countries they have a council which they collaborate together and try to help each country, the other country. And sometimes regarding the material, the supply, they have no problems. The only problem they may facing are the human resources, the human workforce. So what happened in the past? They exchange some of the expertise. And one of the biggest example is the Hajj period and the Umrah period. Sometimes we ask the people who are expert in trauma and ICU surgery from GCC country to work in the Mecca region or Medina region. So there is some sort of collaboration to try to overcome a crisis or pandemic in the GCC. In the Arab region, I had the experience during Gaza attack from our enemy Israel when they attack Gaza. So we have an urgent call from the Arab Ministerial Council to try to help the Gaza region. I don't know what is the situation right now. Is there any way to help, for example, other countries in their crisis? But I know that my country, Saudi Arabia, we have King Salman, the King Salman relief center or helping center, مركز الإغاثة الإنساني خدمة حرمين الشريفين الملك سلمان. So they build hospitals in different regions, in different countries in the Arab region, in Yemen, in Iraq, some part of Jordan to help refugees of Syria and other countries. And they send a lot of supply in order to face the problem of COVID-19 to other countries other than GCC. So I think this is an issue is a little bit political. Need a political commitment from our leaders to help each other. Second, it is that it means that the Arab Ministerial Council, Health Ministerial Council, should work in a proper way that they can utilize the over production of doctors and nurses in Egypt, for example, to help other countries who are lacking behind in human workforce, and so on and so forth. We tried this one during Dr. Hamad Al-Mani, His Excellency Dr. Hamad Al-Mani, for the family practice and other areas. It succeeded. So I think there are some examples of successful initiatives, but there is no a systematic way, or there is no a system way that the Arab work together during the pandemic to help each other and to overcome the challenges and the difficulties and the problems facing due to the crisis of COVID. I think
is this a failure of the Arab League? Let us discuss it when we listen to AK. AK, the floor for you, please. I know you may rush to another operation now, so let us listen to you, and we will come to the Arab League in a minute.
Prof. Salman, I'm looking for my coffee. I lost it because of your question. Very difficult question. Allah yahdi.
Hello, everyone. Can you hear me?
Welcome.
Welcome.
Thank you for accommodating me, especially given how late I am. My name's AK. I'm one of the surgical trainees in London. I just wanted to speak about a project that we did in one of our busy London hospitals that does trauma surgery. So what we focused on in this presentation is essentially orthopedic care for patients that are having what we deem as emergency neck and femur fracture operations. So in the UK, given our increased average age, we get a lot of patients that have neck and femur fractures, and our best practice tariffs, these are the principal guidance that we have to meet for these fractures, suggests that we have to have an operation for them within 36 hours. Unfortunately, what we're finding was, anecdotally, a significant proportion of these patients going into theatre within these 36 hours of their x-ray showing that they had a neck and femur fracture. We didn't know what the COVID status was, and we weren't getting results back in time. And what a lot of staff felt was there were issues operating whilst using PPE, and it was causing a lot of delays, and people felt like it was suffocating them, and it was affecting morale in general. So we started to actually look at the numbers that were involved. I'll just explain a bit more about what we were actually aiming to try and do. So we wanted to find out specifically the times that were being spent on COVID positive, negative, and COVID unknown patients, and to look at what processes are already in place in theatre in terms of who comes in, where they go, where they're recovered, and what the protocols of the hospital were, and basically try and identify any steps that we could speed up the process and raise awareness in the hospital to try and make a change, and also to introduce it to the rest of the world. So this was a snapshot study looking at all neck fracture patients operated on between the 3rd and 15th of August 2020. The reason why we chose this time was because the practice had been well established at this point. We were well into the pandemic, and there wasn't really any excuse anymore for the hospital to say we're still learning, because it had been at least 3 months into the situation. So what we looked at was the COVID status at the time of the surgery, what the wait time was from when the patients entered A&E until they actually had a swab, and how long we were waiting for a result, and then its effect on how long this caused for the patients, for their time being spent in theatre not operating as a result of their COVID status, and then assessing what protocols are in place for each type of patient, so COVID positive, COVID negative, and COVID unknown. So the current protocol at that time of the study was we had 3 different categories of patients. If you had a COVID positive patient that was confirmed, then all patients were extubated and recovered in theatres with full PPE. Category B, which is the most popular type of patient we encountered, was an asymptomatic COVID unknown patient. And what this meant was that they had to be extubated in theatre, but they can be recovered in the recovery unit, and full PPE was still required. And the category C, where COVID was negative and no precautions were necessary, and then we can recovered in recovery unit without any PPE at all. So what we were relying on essentially was, well, what the hospital was depending on was early swabbing, early results. And one other thing was, if the patient had already been in the hospital, was having a valid swab 72 hours prior to the operation. What we were finding was patients were actually being swabbed on the wards. So I'll just present what sort of effect this had. So in terms of the number of patients with 13 neck fractures, none of them were found to have positive COVID status, but more than half of them had an unknown COVID status at the time of the operation. We found that the average time to swab a patient from A&E was 7.5 hours. So that's how long it was taken to actually just swab the patient when they presented to A&E. The average time to swab or to get a results after the swab was 14 hours. So that's half a day essentially of how long it actually took to get a result back after being swabbed. And then this is effect that it's had. So we looked at the average turnover time per patient. So what that means is when the operation finished until the patient leaves theatre, it's a dead time essentially. For a COVID negative patient, that average time was 15 minutes. But for a patient we didn't know the status of, it was 40.7 minutes. That's almost three times longer. What made things worse was the protocol was about to be changed in that only one category C patient, so a COVID negative patient, can be recovered in recovery at any point. And obviously there are multiple theatres that exclude just neck fracture patients at trauma theatre. There's also general surgery, gynecology, etc. One thing that might help was that they were going to increase the swab validity time, so to include 5 days prior. And obviously other issues is what other effects is going to have on urgent and semi-urgent or elective procedures if this is the global protocol. And one thing we didn't look at, but would have been interesting to look at, was how many patients were cancelled as a result of these delays that the unknown COVID status was causing, and whether or not there are similar snapshot studies done like this. So, I mean, essentially, it's clear to say that there was too long of a wait time until the patients are actually being swabbed, evidently slower flow in theatres. And if more than half of the cases were unknown at the time of theatre, and as we know, none of them were positive, that's a significant amount of PPE wastage. And the other thing as well is we don't know the COVID status, so there's also the avoidable exposure to the disease to ward patients and even staff. So our recommendations from this was to swab the patients as soon as the neck femur fracture was confirmed in A&E, have more frequent swab availability and more staff that can actually swab a patient so that there are less barriers to swabbing, and more regular swabbing on the wards. One thing that we did actually implement as a result of this as well is on our WHO surgical checklist for these patients that we implemented, checking what the COVID status is as well, which is a dynamic change to the current situation we're in, and we don't know how long we're going to be in this situation for.
Thank you, AK. I mean, just to add on to that, I mean, in summary, we're seeing a delay of almost 21 hours before getting a COVID result. A lot of these patients cannot wait 21 hours, roughly 22 hours. So the operation goes ahead regardless. And as you can see, the effect on how long it takes, the turnover time between each patient, as a result, we're operating less and our turnover is much less. And as a result, more patients are being pushed to the next day. And that means that those patients are staying in hospital, increasing their risk of catching coronavirus. You know, and it's really quite a mess as a result. So, you know, this audit was really quite amazing. It's highlighted the fact that there is a need to try and make this more efficient. This is something that is not just the UK can take on board. You know, countries that are, you know, whether it be the wealthy GCC countries or poorer Arab countries, you know, can take this on board, because really this all is down to early swabbing and ensuring that there is a system in place to make sure that patients are recovered quickly and away from patients that potentially have coronavirus. So the way that we've categorized, or the hospital has categorized, if I just go back here, the category ABC is a very good way of approaching this. However, you know, how we go about each category can be, I think personally, can be made more efficient. It'd be good to hear your thoughts.
Well, thank you very much, Bob. Thank you for this really, KA and David, for fascinating understanding of surgery from the front line. And I'm really reflecting that in Arab countries, with the exception of those in the GCC, which are wealthy countries, the others, we don't know how much of these patients put at a risk. Because David, as you said, from KA slides, clearly that there is a delay, substantial delay. So there is a risk to the patients. Secondly, there is a risk to the staff who are admitting to the theater as part of emergency, or even a surgery which must be done. There is a huge risk to the staff. And we know that a number of colleagues from surgery, from medicine, lost their life in this fight against the pandemic. And all collectively around the world appreciate the work of our health services staff at all levels. So how can we avoid that risk in the future?
That's a good question. I think if we boil it down to two overly simplified facets, you can look at it at the point of diagnostics and pure exposure. In terms of diagnostics, it's all about microbiology in terms of can we get a swab done and can we get the results done? So in the hospital that the study was done, there was 2 different machines that would do the swabbing or get the results for the patients. There was a slow machine that would take almost 12 hours, and there was a fast one that we called the Samba machine, which took 2 hours. And that's factoring out transporting the swabs from a specific location, getting porters to bring it to the microbiology lab. So all these things would just add on extra amount of time. If there was a more dedicated and essentially, if there was almost like a hot list for these emergency patients or reserved places for them, then it probably that could be one of the ways of doing it if you couldn't afford to just have more machines that could do it, because that's obviously the rate limiting step. Because I don't think swabs availability was an issue. I think it was just the fact that they just didn't have the capacity or the machines to do it. And then the other barrier is just making sure that people were swabbing them. So training A&E staff or more frontline staff to do it sooner.
I think the difficulty that we had in that hospital was that the guidelines were not in place early enough to allow the emergency department to take those swabs early. And it was on the onus of the ward nurses to take the swabs once the patient was admitted to the ward. So once the pragmatic decision was made, okay, this patient needs to be admitted, as I talked about earlier, once that decision was made, they were sent to the ward essentially with an unknown status and without a swab being taken. I mean, we're not expecting to have an immediate result. We don't have the laboratory at the front door, but at least having guidelines in place that can allow give the power to the emergency department to take those swabs is one step. And the other step, as AK mentioned, to be able to utilize and make use of the machines that we had. A hot list is a brilliant idea. So, we short of having another machine specifically for theaters, which would be an ideal, given an unlimited resources and money, which we simply did not have. To say that actually between the hours of 6 a.m. and maybe 7 a.m., in order for that machine to be dedicated for any patient that's due for theater that day, whether it be trauma and orthopedics, general surgery, breast surgery, urology, etc. Any patient that needs an operation that day, their blood will be going through that machine, and it's only them. After 7 a.m., it can go back to the medical patients. Before 6 a.m., it could be back to the medical patients. But in order to utilize that machine at the right time so that we can save potentially 2, maybe 3 hours throughout the day of operating, which means that we can squeeze another 1 or 2 cases in and then, help, reduce the knock-on effect that we were seeing.
AK, sorry, I called you KA earlier, my apology. AK, I think in the certain circumstances and in the way David described and you, that a lot of decisions, before I go to Professor Khoja, a lot of decisions are taken by junior doctors and other staff within the team, taking big responsibility on their shoulder if something happened unexpectedly wrong. I mean, how that's stressful to people like you and David and the nurses and the team. They are talking about big team within our hospitals and hospitals in the Arab world.
I think, here, there's a big step up that at least from the point of view of a junior doctor, seems to make at very certain points. So we start off with F1 and F2, which is when you're fresh from medical school. It's almost like an internship. But the moment you transition from F2 into whatever specialty, surgery, medicine, or GP, psychiatry, or radiology, the expectations and responsibility for you it's a very big step up. So in that initial month, it does feel like a huge burden, and you definitely have a lot of fear. But the countermeasure is that you have to depend on your seniors a lot more, ask them a lot more questions, and conversely, they have to also essentially trust you less and support more. In context of this COVID crisis and being a senior house officer on orthopedics during the pandemic, there was a significant amount of pressure and almost blame culture in regards to COVID status, because we were noting that anecdotally it was delaying procedures and had a long-term effect on other patients and staff. You had to take it upon yourself to make sure the patients are being swabbed as soon as possible. And if they weren't being swabbed on the ward, or if A&E were refusing to swab them because they didn't have the guidance or the protocol in place, then you would find a swab yourself, make sure you knew how to do it, and take it to the lab personally and have it at least that peace of mind. I think, at least in the UK, the management role and the improvement role is shifting over to more junior members of staff. And so they're encouraging us to do projects like this, where we're demonstrating a problem and we're implementing our own recommendation. And it's essentially a mandatory thing now for progression at pretty much every facet. I think even medical students are being forced to do them now. And it's a good thing, because we're becoming responsible for any positive changes, because we're the front line. We see the problems at the shop floor. So we're essentially best suited to try and address them.
Thank you very much. Professor Khoja.
Thank you so much, Professor Salman. Thank you, my colleague, Dr. Eki. This is great to listen to you and to have a taste of the experience you are facing during the pandemic. I have two questions. One in short, and then I come in detail. First one about the impact of COVID-19 on surgical services, and the other one, the role of telemedicine and virtual services for surgical medicine.
Face the mic. Face the mic. We cannot hear you well.
I am sorry.
We didn't hear the second question.
No.
The second one is about the role of the telemedicine and virtual services. So let me start with the first one. Navigating IBHAR on the time of COVID-19. We know that there is a great impact and pressure on the health system as a whole and the human workforce, medical workforce. My question, does COVID-19 put pressure on hospital surgical bed, on ICU bed, or it is this issue, in your hospital, the surgical hospital bed and the ICU bed for surgery was allocated and nobody touched it? I want to hear from your experience. The second question is what is the role of the telemedicine in surgical services? Does it have a role? I can see it in bronchial asthma, in diabetes, whatever. Huh? But how about in surgery? So the questions, if you allow me. 2 minutes to go. Huh?
We have 2 minutes to finish. Carry on.
So after you, okay, yeah.
So in regards to orthopedics, especially, well, the other hospital that I was just at, in terms of telemedicine, there was a certain number. I mean, we're moving over to something called virtual fracture clinic anyway for a lot of cases, in which essentially a consultant will review an X-ray and there'd be a referral from a referring doctor with a history and examination, and those patients can be triaged without having the patient in front of you. And then if there are concerns, then you can ask the patient to come in. The way they were doing it at Epsom and St Helier Hospital was they were doing teleservices, and they were even doing video clinics where they were presenting, just asking patients to use their phones or their cameras to show the joint or the foot or whatever. And then if there was a facet of the examination that was not able to be done via the camera, or if there was an increased concern from what the patient was saying, then at that point you would try and implement or try and get them in and be seen. And you'd have to be wearing full PPE for these patients because their COVID status would be unknown.
Very briefly, David.
Yeah, I agree with that. As I mentioned earlier, firstly, your first question, Prof. Khoja, the impact of COVID-19 on the surgical services. Yes, we saw surgical beds being taken away, allocated to medical patients, coronavirus patients. We even saw some theaters and some recovery areas being allocated to, ventilatory support for coronavirus patients. So we did see some services be, taken away from us, including the elective centers that I mentioned earlier that were converted into intensive care units. But absolutely, I agree with AK. The previous hospital that we both worked at was using telemedicine even before the coronavirus. So the coronavirus was almost a catalyst in speeding that process up, and we could take that forward into the future, to prepare ourselves for a future pandemic, for example, or even just to actually alleviate the pressures on the services and the very precious resources that we have, and the amount of staff that we have. So we're able to then, see patients remotely, even beyond the pandemic.
I promise you, in the next 5 years, our hospitals will look totally without comparison to the current one. You wouldn't recognize it. Health services will change radically. At the end, let me thank you very much indeed, Dr. Badreyya, for your leadership and your valuable time. AK, for your superb contribution and your research with your team, your colleagues, and especially leaving the theater to join us. I'm really grateful for that. So is Professor Khoja and all members of the association. David, thank you very much. You being star today, you managed to educate us about a lot of things. I must say, we have so many questions. 1.5 hours did not cover this. At the end, let me thank everyone and wish you a very festive season. You know what I'm wearing. This is for the Christmas and the birth of Prophet Isa alayhi salam. And we wish you a Merry Christmas to everyone, all our colleagues across the Arab world, and a very Happy New Year. We will be on a break as colleagues at Imperial College, especially Chido, and the rest of the team will be away from the 18th. So Professor Khoja and I will meet you early in the year. And we have so many topics. Maybe we start with universal health coverage, strengthening certain aspects of services, looking at health system resilience. Colleagues from our membership suggested so many topics. So until 2021, I wish you all the best. Have a good evening, good afternoon, good morning. Take care. Bye-bye.
Bye-bye. Assalam.
Merry Christmas.
Thank you. Allah bless you all. Thank you very much. Assalamu alaikum, Badreyya.
Thank you very much, everyone.
All the best. Thank you very much.